welcome back to my channel. So in this video I'm gonna be talking about hyponatremia from a clinical point of view, how to investigate and manage it, which is a very important topic in the hospital setting. So first thing, hyponatremia is defined as a serum sodium concentration below 135 milliequivalents per liter. That is the minimum. Anything under that is hyponatremia. Now it has different grades of severity. Severe means a level under 120, and that should be treated more aggressively. You should be you should treat this patient with higher priority, especially if they are symptomatic. Now, what's the problem with a low serum sodium concentration? You guys know the concept of osmosis, meaning that if there is less water in this region and more water in this region, water will move from the area where it's a lot to the area where it's little, right? So in the case of hyponatremia, that means we have low sodium concentration in the blood. That means we got more water, right? The water will therefore move from the blood to the brain. That's the most important organ we're concerned about here. That means that the sodium concentration in brain cells is higher, and so water will move into the brain cells and interstitium, and that's a huge problem because it can lead to cerebral edema, and that is responsible for the symptoms of the mental status changes that these patients experience, especially with severe hyponatremia, up to seizures. These people get weakness and headache, fatigue, altered mental status, irritation, all these stuff. Okay? It doesn't just affect the brain cells, it affects all body cells, including your muscles, and that's why people would be weak and ataxic, including nerve cells everywhere else. But we're mainly concerned with the brain. And for that reason, it's important to talk about it and treat it. Now, because there's so many different reasons for hyponatremia to develop, it may not even be true. We first need to evaluate it, okay? So evaluation of hyponatremia starts by knowing whether it's true or false. What does that mean? You guys know that sodium dissolves in water of plasma in the blood, but that's not the only part of blood. You have other components of blood, which are proteins and lipids, plus the red blood cells, of course, and the blood cells. But I'm talking here about the plasma portion of the blood. Now, let's say that your plasma portion has a changed fraction so that it has more proteins and lipids and less of this salt solution. If you measure it, ultimately it would appear that you have a lower sodium concentration, even though the amount of sodium has not changed. But it's because the serum component or fraction that has the sodium is less, because we are measuring milliequivalents per liter. So we have a smaller volume even though we have the same sodium concentration. So any condition that leads to rise in proteins and lipids, such as, for example, hyperlipidemia, or high proteins like in multiple myeloma, for example, paraproteinemia, will lead to pseudo hyponatremia. That is not true. And in that case, the serum osmolarity is gonna be normal. It hasn't changed because the sodium concentration is the same. Now, there are other conditions where serum osmolarity may even be high, and that's counterintuitive. Even though we have a low sodium concentration in blood, yet serum osmolarity is high. How is that possible? That means there's a contribution by other osmotically active substances, which are glucose, for example, someone having hyperglycemia, urea at very high levels, someone having severe renal failure or uremia, or an osmotically active substance like mannitol. And that brings us to the topic of serum osmolality, which is determined mainly by sodium, contributing to 2 times part of the equation, but also determined by glucose and urea. And so if these levels are high, it would also increase serum osmolarity. But why would it decrease serum sodium? When we have such osmotically active substances in blood at very high concentrations, that would drive more water from the intracellular compartment to the blood. Because of such high osmolarity in blood, more water moves out of the cells into the blood. This free water dilutes the sodium concentration in plasma. And that's why you get hyponatremia despite high serum osmolarity. But we're not concerned with these situations because they're very easy to detect before you even, while doing the same BMP for the patient, you would figure out whether this is true or false hyponatremia. What we're mainly concerned with would be the true hyponatremia, the one that is hypoosmotic, where the serum osmolarity is low, where there is a true sodium loss or a true reduction in sodium concentration. That's what we want to treat, okay? Now, why do we give this topic so much importance? Because there's so many different causes, and each cause is treated differently. So you have to figure out in which category this patient falls under. But before I dive into this, which is the second step in the approach, volume status, I would like to remind you guys of the effect of 2 important hormones on sodium and water balance. The first is aldosterone. Aldosterone is a hormone that comes out when there is a lot of renin. And there would be a lot of renin when there is less blood flow to the kidneys, as in case of heart failure, for example. Or it might be primary hyperaldosteronism or any cause of increased aldosterone. What this hormone does is it retains sodium and water and gets rid of potassium. So it retains both sodium and water together, reabsorbing them into the blood with very low concentrations left in urine. And there's another hormone called ADH, or anti-diuretic hormone. As the name suggests, it's against diuresis, and that's responsible for concentrating the urine. That means it's gonna reabsorb all the free water and leave the urine highly concentrated with high osmolarity. It has nothing to do with sodium, it only reabsorbs free water into the blood. Okay? Now, the first step, as I told you in the approach of hyponatremia, is to check serum osmolarity to determine whether it's true or false. Now that we decided it's true, the next step would be to evaluate the patient's volume status. Why is that important? We want to know whether this patient developed hyponatremia because of a lot of aldosterone, or because of a lot of ADH around, or something causing that, or is it because they truly lost sodium-rich fluid? That is the question, because every scenario is different. Let's talk about the first scenario, hypovolemic patient. This is a dehydrated patient who lost a sodium-rich fluid. For example, in diarrhea, this patient lost salt-rich fluid in stool, or vomiting, right? Vomiting or diarrhea, or sweat, or third spacing in pancreatitis. All these conditions result in loss of so much more sodium than water. So in the end, you get hyponatremia. Or it could also be renal loss in diuretics, for example, or polyuria. Here, this patient is losing sodium in their urine. In all of these conditions, what's the patient's volume status? This patient is dry. And as a result of the sodium loss in their body fluids, their hormones are active now, trying to retain water, retain sodium, and trying to compensate. Now, the treatment for this patient would be to compensate them. This patient will have dry mucous membranes. Look at their tongue, look at their skin, and assess them. Look at their blood pressure, orthostasis, okay? So now that this patient is easy to identify and easy to treat. Just give them fluids. Mainly we'll start by normal saline, okay? And if the patient doesn't respond, or let's say the patient has severe hyponatremia or is symptomatic, you can even give them hypertonic saline. All right. Now the other category of patients, those who are hypervolemic, the volume status here is overloaded. What do you expect here? This patient is retaining sodium and water, but is retaining water to a greater degree. Why do you think this is the case? So those are usually patients with organ failure, patients with heart failure, renal failure, liver cirrhosis, or nephrotic syndrome. They have a very high level of aldosterone in their blood, which is retaining sodium and water. And at the same time, they also have a high level of ADH because of their low cardiac output or low renal blood flow to the kidneys. And this increased ADH will retain free water, and the free water will dilute the sodium. And so this patient is overloaded. They have a lot of fluid and a lot of sodium at the same time, but the free fluid is higher, and that's why the overall concentration of sodium is low. So in heart failure, there's low cardiac output and low blood flow to the kidneys, and low volume. When you have low volume, the hypothalamus starts secreting ADH. For renal failure, there is a lot of renin, and for liver failure, there is some sort of hypotension and low renal blood flow, which also increases aldosterone. Now with nephrotic syndrome, this patient has a lot of edema, and all their fluid is outside in the third space because of low albumin. So they don't have much intravascularly, and so the same thing, it also increases aldosterone and ADH. This patient is also easy to identify because they are overloaded. They are congested and edematous. The deal with this patient is to start giving them diuretics with caution and to do fluid restriction in an attempt to concentrate their plasma sodium. So that's also easy to identify. And if the patient doesn't respond to these, you can also give them salt tablets, you can give them hypertonic saline, you can give them urea. And the good thing about urea is that it causes osmotic diuresis. So it gets rid of all the extra free water because it's an osmotic diuretic, and therefore concentrates the sodium. Now to the euvolemic type. Here, this person has low sodium concentration in their blood, but they're neither congested nor dehydrated. They're just retaining extra free water. Now, because this is free water without sodium, unlike this patient, they will be euvolemic. They have nothing extra in their third space. They're not congested. Their kidneys and heart are functioning perfectly. Okay? So the deal with these patients is that it is a problem with concentration only. They have a low sodium concentration? Because it's swimming in a lot of water, because they are retaining more water. Okay, now why are they retaining more water? Conditions like SIADH, syndrome of inappropriate ADH secretion, they have a lot of ADH retaining free water, but they can still get rid of any extra, so they're euvolemic. Their heart is fine, their lungs, their kidneys are fine. Okay, that's the difference. What else? Some drugs cause this effect, cause increased ADH as well, especially psychogenic drugs like antidepressants, antipsychotics, stuff like that, even anti-epileptic drugs, and adrenal insufficiency, because adrenal insufficiency means you do not have enough cortisol or aldosterone. So that means you're not keeping your sodium in. And if you're not keeping your sodium in, that means it's going to be diluted in the free water. So in the end, you're going to have hyponatremia, right? Or severe hypothyroidism for a similar effect. Or some people who drink a lot of free water without eating much, or beer, something called beer potomania, where they just drink beer and don't eat much, so they don't get enough salt in their diet, or the tea and toast diet. In both cases, they're essentially diluting their blood, right? Now, how do you figure out these conditions? You can simply suspect that this is the case if the patient is euvolemic and you do urine sodium and urine osmolarity, as I'm going to mention later, plus those tests. You can test for thyroid functions, T3, T4, TSH. You can test for cortisol in the morning. You can test for ADH levels in the blood, right? Now, I am just in the second step. I'm only here in the second step of identifying the hyponatremia. But until here, you can still treat. But you wouldn't really be sure, 100% sure, unless you move to the urine osmolarity and urine sodium step. And here is where the catch is. So, I told you guys before that aldosterone retains salt and water in blood so that the urine becomes concentrated, and so that the urine doesn't have much sodium. It's going to have very low sodium. So any condition where you have a lot of aldosterone means that your urine sodium will be low, right? Great. So in conditions where you are dry and dehydrated, your aldosterone levels go up, trying to retain as much water and sodium that you lost as much as it can. In these cases, your urine osmolarity is going to be super high because your urine is concentrated, and urine sodium will be super low as your body's trying to retain it. Unless the main source of loss is renal. Let's say you're dehydrated because you're losing water and salt in your kidneys. In that case, expect a high urine sodium, fine, because this is the source. But otherwise, if you're losing it in diarrhea, losing it in vomiting, expect urine sodium to be low because aldosterone is super active, right? So now we're done with the hypovolemic part. Let's go to the hypervolemic part. We said that in these cases, usually there's a high aldosterone because of low renal blood flow. So in these cases, we also expect high urine osmolarity and low urine sodium because aldosterone is super high and active. Perfect. Now to the euvolemic type. The euvolemic type, as you can see, is highly versatile, and so you get so many different reasons. Let's say it's because of low aldosterone, adrenal insufficiency, or hypothyroidism. In these cases, aldosterone level and effect is very low. In that case, expect to have high urine sodium because no one is acting to retain it, right? Okay, perfect. So in these conditions where you have euvolemic hyponatremia, in most cases you're going to have high urine sodium, except in one condition like beer potomania or psychogenic polydipsia, where someone is just drinking so much free water. So that free water is going to be excreted in urine and it's going to dilute everything in urine. So that means low osmolality because of low urine sodium. So that only applies to conditions where there is polydipsia or beer potomania, where there's nothing wrong with this patient except that they're drinking free water. But if this patient is having a lot of ADH, SIADH, for example, that means they're retaining so much free water in their blood, so their urine is super concentrated. They're gonna have high osmolality, and at the same time, nothing is acting to retain the sodium. Their urine is very concentrated from the ADH, but at the same time, aldosterone level is low because aldosterone level is suppressed because of this patient retaining a lot of free water. Their body feels that they don't need any more fluid, so their body starts suppressing aldosterone. So they're not going to retain the sodium and are also going to have a high urine sodium. So they have a high urine osmolarity because it's concentrated urine, a lot of ADH, and they have a high urine sodium because of suppressed aldosterone. And that is how you figure out for sure. So usually the first step would be to determine whether it's true hyponatremia by serum osmolality. Once you figure out it's true, evaluate the cause by the patient's volume status in order to initiate treatment. Am I going to give fluids or am I going to restrict fluids based on the patient's volume status? But in order to figure out the cause for sure, it's the urine osmolarity and sodium. It's the urine lights, as they call it, that will help you figure out exactly. Now, what are the cutoff values here? When I say high or when I say low for the urine osmolality, I mean a cutoff of 100. Under 100 or over 100. When I say high or when I say low, in case of sodium, we're talking here 40 or 20 to 40. Some people say 20. If it's under 20, actually that is really high aldosterone effect, or over 20. Okay, mainly 20. So the treatment for hypovolemic fluid replacement, mainly for the hypervolemic or euvolemic, it's fluid restriction because we want to concentrate whatever sodium is remaining in this patient's blood. If fluid restriction doesn't work, we can use sodium tablets, salt tablets, or urea tablets. Urea gets rid of the extra free water by being an osmotic diuretic. And if all else fails, you can use an ADH blocker called tolvaptan. And obviously, in a congested patient, you can also use diuretics like Lasix, which gets rid of extra water more than the sodium. Don't give thiazide because thiazide may cause hyponatremia. Give Lasix or furosemide or any of the loop diuretics. I hope this video helped, guys. Let me know what you think.